A very good morning to all of you students. Today we are going to discuss about cervix and its pathology. Before going into the topic proper, we will discuss about the normal anatomy of cervix. Cervix connects the uterus interiorly and to the vagina exteriorly. The cervix has two os, that is internal os which connects to the uterus and the external os which connects to the vagina. So the cervix is the lower end of the uterus. In the adult, the cervical and the endocervical region comprises 1/3 of the length of the uterus. The outer cervix is lined by stratified squamous mucosa containing abundant glycogen. The underlying fibrovascular connective tissue of the lamina propria merges with the smooth muscle bundles. At the cervical os, the squamous epithelium changes to a tall columnar mucinous epithelium. This junction is called a squamo-columnar junction. So this is the colposcopic view of a normal anatomy or normal aspect of the uterus cervix. So this is the external os and this is the internal os. The point of transition, the external os which is covered by stratified squamous epithelium and the internal os is covered by columnar epithelium. The transition of the columnar epithelium to the squamous epithelium, the junction of transition of columnar epithelium to the squamous epithelium is called as squamo-columnar junction. So, look at this picture. The border at which the columnar epithelium changes abruptly into the squamous epithelium is called as squamo-columnar junction. Just above the squamo-columnar junction lies the transition zone, a zone of columnar epithelium that is undergoing a gradual change into the squamous epithelium. This transition zone is the place where most cervical abnormalities occur, both malignant and non-malignant. It is for this reason that it is critical to make sure that both squamous and columnar cells are gathered from the transformation zone when making a pap smear. This is the transformation zone. As you can see, these are all the reserve cells which are located basally, and these are all the columnar cells. Endocervix. This is the ectocervix which is lined by squamous cells. This is the squamo-columnar junction, the area at which the columnar cells gets transformed to the squamous cells. Okay. So this is the histopathological picture where you can see the columnar epithelium. This is the higher magnification of the columnar epithelium. You can very well see the columnar epithelium is getting transformed into the squamous epithelium. So, the position of the transformation zone changes throughout each woman's life. That is, before the onset of puberty, the transition zone lies inside the endocervical canal. After puberty, during the fertile years, the transition zone moves more in the direction of ectocervix. In the post-menopausal years, the transition zone often recedes back into the endocervical canal. Let us now look at how abnormalities develop in the columnar epithelium of cervix. In the zone of exposed columnar epithelium, the first indication of an irritation to the mucous membrane is the replacement of columnar cells by primitive cytoplasm poor cells. That is called as reserve cell hyperplasia. As you can see, this is the normal columnar cells with reserve cells. After any irritation to the mucous membrane, there is reserve cell hyperplasia. When irritation continues, these reserve cells can change into abnormal cells, either of the squamous metaplastic type or of the columnar type. The squamous cell carcinoma can develop from squamous and squamous metaplastic epithelium, and adenocarcinoma can develop from columnar epithelium. So this is the normal cervix which is seen at higher magnification. These are all the basal cells. The basal cells are seen at the right, and there is progressive maturation to the surface where the flattened squamous cell have low NC ratio. See, that is, it has abundant cytoplasm containing glycogen and epignotic nucleus. This is the area of maturation. These are the basal cells. You have intermediate squamous cells and you have superficial squamous cells. So this is the squamo-columnar junction. Normal cervix with stratified squamous epithelium, not keratinizing stratified squamous epithelium, merges at the transformation zone to the endocervix, which is lined by tall mucinous columnar cells. Now, having seen about the normal anatomy of cervix, now we will discuss about some of the pathologies of cervix. So, the cervical pathologies can be divided into benign category and malignant category. So, the benign diseases of cervix can again be subdivided into inflammation, metaplasias, some of the benign tumors, and some of the cysts. So, what are all the inflammations that can occur in cervix? Inflammation can be categorized into two types. One is acute inflammation, the other one is chronic inflammation. Whenever there is inflammation, you can call it as itis, cervicitis. So acute and chronic cervicitis. Then you have metaplasias. What is metaplasia? Metaplasia is nothing but transformation of one type of epithelium into another type of epithelium, which is called as metaplasias. Okay. Then you have hyperplasia, ariostellar reaction, and endometriosis. Then you have some of the benign tumors. Benign tumors in cervix includes endocervical polyps, leiomyomas, and adenomyoma. And some of the cysts, Levothian cyst, tunnel cyst, and inclusion cyst can occur in cervix. Next, moving on to some of the precancerous lesion of cervix. Precancerous lesion or the lesion that precedes the carcinoma. These are all called as squamous intraepithelial lesion. And these lesions can again be divided into two types. One is low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion. So the low grade is comprises of condyloma and CIN1. Now there are several classifications for these precancerous lesion of cervix. The first classification that was used earlier years back is carcinoma in situ classification. The second classification is CIN, cervical intraepithelial 1 neoplasia classification. There you have CIN1, CIN2 and CIN3. Now we are not using any of these classifications. We are using only Bethesda system, that is LCIL and HCIL. LCIL stands for low grade squamous intraepithelial lesion. HCIL stands for high grade squamous intraepithelial lesion. Then you have certain glandular intraepithelial lesion, low grade glandular intraepithelial lesion, and high grade glandular intraepithelial lesion. Now, then you have carcinomas. I will discuss about the classification of carcinoma in my subsequent slides. Now you have acute and chronic cervicitis. So menarche, during menarche, the production of estrogens by the ovary stimulates maturation of cervical and vaginal squamous mucosa. So these cells are shed. The glycogen provides a substrate for endogenous vaginal aerobes and anaerobes, streptococci, enterococci, escherichia coli, and staphylococci. The bacterial growth produces a drop in the vaginal pH. So what will be the morphology of cervix? In acute and chronic cervicitis, there will be epithelial spongiosis. Spongiosis is nothing but intercellular edema. There will be submucosal edema and a combination of epithelial and stromal changes. Coming to acute cervicitis, there are certain acute inflammatory cells, erosions, reactive or reparative epithelial change. In chronic cervicitis, you can see mainly mononuclear cells such as lymphocytes, macrophages, plasma cells. There can be necrosis and granulation tissue also. In case if it is infection because of human simplex virus, herpes simplex virus, there are epithelial ulcers and a lymphocyte infiltration. In the epithelial ulcer, you can see intranuclear inclusion in the epithelial cells in case of herpes simplex virus infection. And some of the sexually transmitted infections like chlamydia trachomatis, you can see lymphoid germinal centers and a prominent lymphoplasmacytic infiltrate. So cervicitis is most often caused by sexually transmitted pathogens, but may also be caused by systemic disease such as autoimmune diseases, Stevens-Johnson syndrome, or certain viral infections. Some of the neoplasias can also cause cervicitis, and trauma. It can be either mechanical or chemical trauma. Okay. So the two main sexually transmitted agents which are responsible for clinically apparent mucopurulent endocervicitis are chlamydia trachomatis and Neisseria gonorrhoeae. So these produces mucopurulent endocervicitis. And herpes simplex virus causes an ectocervicitis as a Trichomonas vaginalis. So herpes simplex virus and Trichomonas vaginalis causes ectocervicitis. So chlamydia and gonorrhea are responsible for mucopurulent exudate. Next, the exposed endocervix is sensitive to these chemical changes in the environment, and the bacterial flora responds by undergoing a variety of changes, including proliferation of reserve cells, leading to squamous metaplasia in the reproductive years. Okay, this is associated with a mixture of inflammatory infiltrate of polymorphonuclear leukocytes, mononuclear cells, and if the inflammation is severe, it may cause loss of epithelial lining and epithelial repair. During epithelial repair, you can see certain cells which are similar to that of the carcinoma cells. So you can confuse very well with these cells, and that condition is called as reparative atypia. During the process of repair, there will be some atypical cells. So these cells are not malignant cells. So you have to be very careful in differentiating reparative atypia from carcinoma. So all of these components characterize what is known as chronic cervicitis. Next, moving on to our next important benign lesion of cervix that we encounter most often is squamous metaplasia of cervix. So what is the etiology? The most common etiology is associated with irritation, inflammation, and low vaginal pH. So the appropriate stimulus triggers squamous rather than glandular differentiation from the basal cells. So this is the normal finding in most of the reproductive age women. Grossly, you will see tan gray surface which is similar to that of mature squamous epithelium. Microscopically, in the transformation zone which is bound by a proximal margin of current squamocolumnar junction and distal margin of the original squamocolumnar junction. As I told you earlier, metaplasia is nothing but transition from the columnar epithelium to the squamous epithelium. The columnar epithelium is not able to withstand the stress. That is why it is getting transformed or adapted to another epithelium which is able to withstand these stress. Okay. So this is a histopathological picture of squamous metaplasia. Next important benign lesion that you can encounter is microglandular hyperplasia. This results from progesterone stimulation of the endocervix. The most common cause of microglandular hyperplasia is pregnancy and old-fashioned contraceptive pills, that is progesterone only pills. The glands are abundant and have only a lazy stroma between them along with many neutrophils. Some of the cysts, that is Nepothian cyst. This Nepothian cyst occurs because of overgrowth of the squamous epithelium which obliterates the surface columnar papilla. As I told you earlier, under the columnar epithelium, you have numerous mucus glands. So obliteration of the ducts of these mucus glands by the overgrowth of these squamous epithelium causes cyst which is called as Nepothian cyst. Then you have cervical leiomyoma. Cervical leiomyoma is nothing but a smooth muscle tumor which is most commonly seen in the uterus. It can also occur in the cervix, but it is very less common. Okay. They causes unilateral enlargement of the cervical portion. Leiomyomas are usually spherical and they are firm. The cut surface are white to tan with a whorled trabecular pattern. Microscopic findings of the leiomyomas is composed of whorled anastomosing fascicles of uniform smooth muscle cells. Next is endocervical polyps. These are inflammatory benign tumors. They occur in 2% to 5% of adult women. The major significance of polyp lies in their production of irregular vaginal spotting or bleeding. Most polyps arise within the endocervical canal and vary from small and sessile to large 5 cm masses. Morphologically, they are soft, almost mucoid, and they are composed of loose fibromyxomatous stroma harboring dilated, mucus-secreting endocervical glands, often accompanied by inflammation and squamous metaplasia. The treatment of choice is simple curettage or surgical excision. So this is a histopathological picture of endocervical polyp. Here you can see them lined by the endocervical mucosa. Next, moving on to the classification of the tumor. Having seen about the benign tumor, pre-malignant lesions of the cervix, which I will deal in detail. Now we will just see the classification of carcinoma. Then we will move on to the pre-malignant lesion of the cervix. Carcinoma of cervix can be classified as invasive carcinoma. Under invasive carcinoma, you have squamous, adenocarcinoma, adenosquamous carcinoma, glassy cell, mucoepidermoid, adenoid cystic, neuroendocrine, small cell, and differentiator. And some of the mesenchymal tumors and tumor-like condition that arises in the cervix, like leiomyosarcomas, endometrial stromal sarcomas, sarcoma botryoides, etc. And you have melanocytic tumors like melanoma, yolk sac tumors, dermoid cysts, mature cystic teratoma, everything can occur in the cervix. Now moving on to the pre-malignant lesions of the cervix in detail. Now we will see about cervical intraepithelial neoplasia and carcinoma of cervix. Now we will see about CIN1. I've told you earlier itself, this classification is no longer used. CIN1, 2 and 3 is no longer used. Instead of that, we use LCIL and HCIL. Okay, LCIL is nothing but it is composed of CIN1 and HCIL is composed of CIN2 and 3. That I will tell you in my subsequent slides. What is CIN? CIN is nothing but cervical intraepithelial neoplasia. It is one of the leading causes of cancer deaths in the women. There is a gradual decline in the incidence of CA cervix because of the availability of simple, cheap screening methods, that is the pap smear. Increased awareness also contributed to the decline of carcinoma cervix. Pap smears can detect the lesions in an early stage when it is still curable. So what are all the risk factors of CA cervix? Early age at first intercourse, multiple sexual partners, increased parity, a male partner with multiple sexual partners, presence of cancer-associated human papilloma virus, persistent detection of high risk of human papilloma virus in the pap smears, certain HLA and viral subtypes, exposure to nicotine and oral contraceptives, and certain genital infections with chlamydia. So the most important risk factor of CA cervix is human papilloma virus that you have to remember. The human papilloma virus has several subtypes, that is high risk subtype and low risk subtype. So you have to remember the numbers of high risk subtype, that is 16, 18 and 45, and low risk subtype is caused by 6 and 11. And there are certain genes, that is HPV has certain genes such as E6 and E7. These genes disrupt the cell cycle by binding to retinoblastoma with upregulation of cyclin E. This helps in increased cell production. They interrupt the cell death pathway by binding to P53. They induce rapid degradation of P53. So majority of cancers are preceded by precancerous lesion. These precancerous lesions may exist for 20 years before invasive carcinoma develops. During this period, pap smear shows abnormal cells. Most of the cancers are associated with HPV high risk. Not all precursor lesion proceeds to malignancy, but some may progress also. So as I told you earlier, the CIN1 is now called as LCIL. The CIN2 and 3 is called as HCIL. What is CIN1? There is nuclear enlargement and hyperchromasia in the superficial layer, that is only top 1/3 of the squamous epithelium is involved. Upper 1/3 is only involved. There is light nuclear enlargement and hyperchromasia. This indicates active viral replication in the superficial mature squamous cells. There is coilocytic atypia. The lesions can be raised or flat. Raised lesions are usually caused by low risk virus and flat lesions are usually caused by high risk HPV virus. This stage is reversible. Coming to the morphology, on the extreme low end of the spectrum are lesions that are often indistinguishable histologically from condyloma acuminata, and they may be either raised or flat in appearance. Such changes fall within the range of CIN1, that is low-grade intraepithelial neoplasia. CIN1 often contains abundant papilloma virus nucleic acid, and the raised lesion often contain low-risk HPV virus. Flat CINs usually contain high-risk HPV virus. This is a picture of condyloma acuminatum. The genital warts are spread by sexual contact. Approximately 2/3 of the individual who have sexual contact with an infected partner develop genital warts. HPV causes a spectrum of changes ranging from condyloma acuminatum to invasive squamous cell carcinoma. These lesions typically exhibit nuclear enlargement and hyperchromasia in the superficial layers, signifying the effects of acute viral replication in the maturing cells. This is called as viral cytopathic effect. The nuclear changes may be accompanied by cytoplasmic halos, that is coilocytic atypia with few alteration in the lower epithelial cells. These are all the coilocytes. Coilocytes are cells which are large with abundant glycogen and hyperchromatic nucleus. Another picture for coilocyte. This is another picture showing coilocytic atypia. What is CIN2? Two-thirds of the epithelium show nuclear changes and mitotic activity. They are highly associated with high-risk human papilloma virus. They exhibit aneuploid cell population. E6 and E7 induce genomic instability and inactivation of P16. This is a cervical biopsy where you can see dysplastic cells in the lower one-third. But the basal lamina is intact. This is CIN2. What is CIN3? There is progressive loss of differentiation. There is atypia in all the layers. No surface epithelial differentiation can be seen. The atypia is seen up to the basement membrane, but there is no breach of the basement membrane. Can you see? The atypia is seen in all the layers. So the progression is not always simple. From CIN1 to cancer, low-grade lesions and condyloma may not progress to cancer. High-grade lesions may progress to carcinoma. However, it is not possible to predict the progression in a given patient. In situ invasion may take up to 20 years. Now coming to the next topic, that is squamous cell carcinoma. Squamous cell carcinoma may occur at any age from second decade of life to senility. The peak incidence is occurring at an increasingly younger age, that is 40 to 50 years for invasive cancer and about 30 years for high-grade precancers. This represents the combination of earlier onset of sexual activity and active PAPS screening in programs in United States. The clinical feature of squamous cell carcinoma includes postcoital bleeding, 80% of squamous and 20% of other presents with postcoital bleeding. It can be diagnosed earlier by pap test. 40 to 50 years is the peak age, and the treatment is mainly by bone biopsy and hysterectomy. This is a histopathological picture of squamous cell carcinoma of cervix. Another picture showing large squamous cell carcinoma which spreads to the vagina. Morphology: invasive cervical carcinoma manifests in three forms: fungating, ulcerating, and infiltrative cancer. When obvious to the naked eye, the most common variant is the fungating tumor, which produces an obviously neoplastic mass that projects above the surrounding mucosa. On histopathological examination, you can see nest of squamous cells. It can be keratinizing and non-keratinizing. If it is keratinizing, you see keratin pulse, and non-keratinizing, you don't see keratin pulse. The cells are very large with increased NC ratio, hyperchromatic pleomorphic nucleus, and abundant eosinophilic cytoplasm. And it spreads down to vagina and labia, laterally to adnexa, ureter, ovary, and pelvic wall. Anteriorly, it spreads to the bladder, posteriorly to the rectum. And lymphatic wise, it can spread to paracervical, obturator, internal and external iliac lymph nodes, and blood it can spread to liver, lungs, etc. This is the staging of CA cervix. Stage 0, carcinoma in situ. Stage 1, carcinoma confined to the cervix. Stage 2, carcinoma extends beyond the cervix but not onto the pelvic wall. And stage 3, it has extended onto the pelvic wall. And stage 4, it has extended beyond the true pelvis or has involved the mucosa of the bladder or rectum. This is the histopathological picture of CA cervix, where you can see nest of squamous cells which breach down the basement membrane into the underlying stroma. Another picture, you can see the squamous cells, squamous pearls. And the next variety is adenocarcinoma of cervix, where you can see the cells are arranged in glandular pattern. It arises from the columnar epithelium of the endocervix. This is a glandular pattern. So clinical course and management. Cervical cancer prevention and control can be divided into several components. So, the main treatment is DH and DSO, total abdominal hysterectomy, and bilateral salpingoophorectomy, depending upon the stage of the lesion. So, cervical carcinoma screening and pap smear. Since the pap smear examination was introduced after World War II, death rates from uterine cervical cancer have decreased by 70% in the US. Pap smear is the most effective cancer screening test so far. So it is a exfoliative cytology. The screening test for cervical cancer, it is simple, safe and non-invasive method which is developed by George and Pathologies. Every woman should have an annual PAPS examination when she becomes sexually active or turns 18 years old. Regular PAP examination should continue even after menopause and after hysterectomy. Okay. So, the best time for PAP examination is during 2 weeks following the end of menstrual cycle. If menopause, PAP examination can be scheduled anytime. This is the normal pap smear where you can see superficial squamous cells, intermediate squamous cells, and numerous inflammatory cells in the pap. So this is a case of low-grade squamous intraepithelial lesion where you can see coilocytes. Coilocytes are large cells with perinuclear halo and hypochromatic pleomorphic nucleus. See, this is another case. Then you can see head cell, high-grade squamous intraepithelial lesion where you can see large cells. These are from the basal cells. These are all basal cells with high NC ratio and minimal amount of cytoplasm. So nowadays, we report the pap smear with the help of Bethesda classification. That is whether it is a normal histological finding, benign cellular changes, squamous lesion that has ascus, L cell, head cell, and glandular lesion that is adenocarcinoma in situ or invasive adenocarcinoma. Thank you.